Dr. Dalia said, please welcome and thank you very much.
Thank you very much.
Please carry on with your presentation. Management of perforated PUK.
Thank you very much for the invitation. So I'm going to speak to you today about perforated PUK surgery and beyond. I'd like to acknowledge my mentor, Professor Harminder Dua, who's taught me most of what I'm practicing. So we really don't want to reach this stage because we know that patients presenting with this situation are going to be losing vision, counting finger, end up with a counting finger vision, 65% of patients. Then if it's unilateral, then mortality increases to 25% in 1 year, and if it's bilateral, maybe 50% increase mortality in a year. So what do we do so that we don't reach this stage? We have to identify the etiology, manage threatening perforation so they don't end up being perforated. We have surgical options for perforations, but the peri and post-operative management are essential, and we have to later on visually rehabilitate these patients. The etiology can be ocular or systemic. The systemic, remember, 20% of them are infectious. So you have to investigate for infectious causes because you are going to immune suppress these patients and you don't want to miss an infectious cause for the PUK. The autoimmune causes represent 50% of the non-infectious causes, and that's why you have to also investigate these profusely. So it starts, as my colleagues have said, with the peripheral ulcers. There is a clear zone. It starts to extend circumferentially. And if you have a patient with rheumatoid arthritis, for example, like this patient who've not been very well controlled pre-operative, and you go and do your cataract surgery, you can end up with a peripheral perforation and infection, like in that case. Moorings is a diagnosis of exclusion. So you have to investigate everything before you say this is a Moorings ulcer. It is idiopathic. If you see scleritis like in the lower picture, then this is not Moorings. It's very painful, unilateral or bilateral, and sometimes there is helminthic infection, genetic factors. Hepatitis C can be association, and even other genetic factors can be associated. So what do you do when you meet a patient with a PUK? Very important to take a thorough history, do systematic examination, exclude infection, as we've said, look for immunological factors, don't forget to do a chest X-ray, and look for inflammatory markers. And OCT is very helpful to tell you how thick is your cornea, how much thinning is there, are you about to perforate or not. And it is really, really essential to liaise with your rheumatologist because sometimes it's difficult to get them on board because they always say if the joints are fine, then the patient is not one of our patients, and we can't. So you have to have serious talks with the rheumatologist. Whenever we get a PUK which is about to perforate, we admit these patients, give them IV methylprednisolone 500 to 1,000 and give oral steroids, and then with the rheumatologist we can give immune suppression while they monitor the patients. And there are a variety of immune suppressive drugs that are used by the rheumatologist, especially the biologic agents. I'm not going to go much into details of this, but if you have a threatening perforation, you can start with topical and oral steroids. You need doxycycline to reduce the melting. You can put a bandage lens or use a multi-layering amniotic membrane, and I will show you some cases. This patient presented to us with a burnt out psoriatic arthritis. So she stopped her methotrexate because the joints were fine. She came with a PUK. It was getting worse and worse, and we put a multi-layer amniotic membrane on the area of the epithelial defect, but we had to admit her, give her IV MP before, and followed by oral steroids with the help of the rheumatologists, and then she was maintained on 20 milligrams per week of methotrexate, and she had very good vision after. This is another example of a patient who was referred from another hospital with recurrent PUK. This time they were not able to treat with the topical and oral steroids alone. We admitted the patient and we give him also oral and topical steroids were under cover of antibiotic, but the patient was getting worse and worse, and you can see here the ulcer is getting worse by the day. And the rheumatologist investigated everything and said everything is negative, this is a Moorings ulcer. So we admitted and give the IV MP. I hope the video will work. So we did the conjunctival resection. The videos, there is a bit of lag in the videos, I think, when I was loading them.
Yeah, they are going to UK network.
I wish, because I've got quite a few videos here. So the conjunctiva was completely resected at the area where the ulcer was. Also the area of the limbus and the epithelium was removed. Very good cautery to that area was done after removing all the epithelium at the edge. And then we had an over-the-counter amniotic membrane, which we used, fashioned to the area of the defect, as you can see here. Obviously, if you have the iBank Omnigen is better, but in this case we didn't. And then we used fibrin glue to glue the amniotic membrane on the edge of the cornea as well as the area of the sclera, and you can even glue the conjunctiva on top of the amniotic membrane like in these patients. But having done all the surgery then this is just to show you how we put the glue and then reflect the amnion back on the sclera. And then the patient described that his nose and ears swells every time he gets a PUK. So although the rheumatologist thought this is a Morin's ulcer, but they actually found a diagnosis. That's how important the history is. So, but it didn't change the treatment much, but at least they were convinced, and then we carried on with using methotrexate 50 milligrams per week while we reduced the oral steroids, and then the patient had very good vision, completely epithelialized 1 month after, and this is the patient here 18 months after, completely stable on immune suppression. Now, if you have a perforation, there are different variety of surgical techniques. You can start with gluing multilayer amniotic membrane, tenons or scleral patches, lamellar or full thickness grafts. So if you're going to glue, you don't want to put the glue on the iris, so you do the double drape technique. So put one plastic disc to cover the iris, and then the other plastic disc with the glue so that the iris doesn't get in contact with the glue. You can also use the autologous scleral patch, and sometimes with time that becomes transparent if you put it on the cornea. And sometimes you get these very complex patients, like this patient I would like to share with you, presented with localized corneal edema, which is unlikely a presentation with PUK, and shallow AC and perforation. She was glued 3 times and getting perforated at different points. But we did the OCT and we could see that they've got a lot of corneal edema. It's not just thinning. And then we did a topography on the other side, and it was undiagnosed keratoconus. All the bloods were negative except for eosinophilia. Then eventually the patient got worse and worse, extensive inflammation up to almost detachment of the limbus. So this patient, we went and removed all the necrotic and all the unhealthy epithelium and stromal tissue, did 200 micron, used the diamond knives to create a 200 micron sclerocorneal disc. So you can use the Mellis dissector after mounting the sclerocorneal tissue on the artificial anterior chamber and do the lamellar dissection limbus to limbus. Then you can actually use a plastic to do the exact area where you need to graft, and then you can split the sclera. You've already dissected the cornea, but you can split the sclera at the same area and then create a stromal, anterior stromal lamellae, where you can put here, you can suture and glue to the area of the defect. So, and then you can actually glue the conjunctiva on top. And this is what we've done with this patient. And the microbiology, we took the tissue samples for microbiology, and they did show that there is some small vessel vasculitis, and the patient was maintained on high dose of steroids, which was decreasing 2-hourly DEXA-free with an antibiotic cover. And this is the patient. She had a lot of inflammation post-operatively, which had to be managed with increased steroids and immune suppression systemically. The sutures loosened and were removed within 6 weeks, and then finally the patient was 6'9" unaided. So with these peripheral ulcerative keratitis, the good thing is that the central vision can be maintained for a long, long time because all the changes happen mainly in the periphery. Another patient with bilateral Morin's ulcer with previous perforation, very large perforation, presented with a large peripheral perforation. So one other technique you can use is that you can use 2 different refines. So this one we used 7.5 and 9.5 refination to create that ring, and you can actually decenter the central one so you can get a thicker rim, and then you take that rim and suture it first before you cut it to the area of the defect, to the patient's cornea, like in here. And once you've got your graft to the area, the size that you want, like in this patient, patient, then you can remove the rest of the cornea. And if it's too thick, then you need to thin it out a little bit so that you don't have a proud edge. Again, these patients have to be followed up with immune suppression. Make sure that you have no leak after you've done your surgery, and then after reforming the AC, and you can glue the conjunctiva on top. And this is the patient in the post-op, done very well. Another option is in these patients glued multiple times, but the perforation was too big. So you can use the manual to refine, and you need to make the sclera partial thickness and to cut the actual cornea full thickness. So full thickness corneal cut, partial thickness scleral cut, and you can use the punch biopsies to create a round perforation, and make sure you make a pupil for the patient and remove any retrocorneal membrane like in this patient, and put suture your graft. And this is the patient's post-op. And then you can make a central graft later on for visual rehabilitation. If you have a large central perforation like this, you can have a large defect. Make sure that when you're suturing, that the surface coapts. It doesn't matter if the inside coapts. So the take-home message is really melting is a sign. It's not a diagnosis. 50% of cases are associated with collagen vascular disorders. It could be a first presentation of a potentially lethal disease, such as rheumatoid arthritis, Wegener's, or systemic lupus. You need to treat underlying and associated conditions. Patients got dryness, has to be treated before you operate on them. Diabetes, any lid abnormalities need to be managed. Any infections need to be diagnosed. Use preservative-free drops, especially with glaucoma, because they can be a culprit. And there are a variety of surgical techniques, but the peri-operative immune suppression is a must. Thank you.
Thank you very much, Dr. Syed, for a very comprehensive talk. Any questions or comments for Dr. Syed? Yes, please.
So if you can,
Dalia, can you repeat the question?
Yeah, how much oversizing? So we always try to oversize by 0.25 when we do grafts. But remember, it's all a percentage. So if you're making a smaller graft, the 0.25 is quite a lot. If you're making a bigger graft, a 0.25 is not too big. So if you're going to make limbus to limbus graft, you probably want to go with 0.5. Because also it reduces the chance of getting glaucoma. It opens up the angle. So 0.5 for large graft, 0.25 for smaller grafts.
In comprehensive ophthalmology practice, we are very scared of using topical steroids in the patient. So when not to use and when to use?
So one very important sign is if you see an AC reaction. If there is AC cells, then there is an element of infection. So, but if there is no AC cells, then you're most likely dealing with a PUK. If it's peripheral, no AC activity, you're dealing with a PUK. Use preservative-free steroids under cover of antibiotics. And if it's very, very thin and you're really worried, use systemic steroids. Use oral steroids. Then, you know, don't give topical. Sometimes I'm careful with topical. Give systemic steroids and monitor the patients. But obviously, you have to do your blood test before, so to know your baseline and to make sure that you don't have any systemic infections.
Any comment on the multiple use of antibiotics?
But if it's not infective, you don't need the antibiotic. See, the antibiotic is just to cover against the infection. If it's a peripheral ulcer and there is no cells in the AC, you're most likely dealing with a peripheral ulcerative keratitis.
Because in periphery we get patients from the village area. They come with 2-3 antibiotics.
So see, that is a distinction you need to make. Like that you do not want to use antibiotics unnecessarily, because they will create resistance and they are not serving any purpose and they are increasing the cost of treatment to the patient. So if you are able to make a distinction, and most of the PUK making the distinction between infectious versus infectious, I'm sure Somsila will cover, but not that very difficult even for a general ophthalmologist. So hopefully by after the end of the instruction course you'll understand those aspects.
Any role of topical cyclosporine eye drops?
I would probably use topical steroids and systemic steroids. Cyclosporin, ocular surface inflammation, it's not, you need systemic treatment. All these patients had to be on long-term systemic treatment managed with the help of the rheumatologist. We are not really geared to monitor patients for systemic immune suppression. That's why you'll always have a rheumatologist somewhere in a nearby hospital where you can liaise, because these patients, their bloods have to be monitored, cyclosporine, they have to do a trough level, or tacrolimus, they have to do a trough level. So you can't really do this as an ophthalmologist in most centers. So liaise with the rheumatologist. Systemic immune suppression will maintain these patients with very good visions for years. And then if you have to take off the systemic immune suppression, then that has to be very gradual with you and the rheumatologist hand in hand.
Any other question, comments? For
your steroid of choice for topical?
Excuse me?
Your choice of topical steroid is prednisolone or?
We use dexamethasone preservative-free in England. I practice in Nottingham.
See, here I would use pred acetate, which is quite freely available. Dexamethasone preservative-free or dexamethasone alone drops not easily available. And so pred acetate really works very well in this condition.
And treatment should be aggressive at the first, and it has to be tapered afterwards.
Yes.
See, doctor, you are missing her point. She said repeatedly systemic treatment.
Yeah.
Systemic.
For PUK autoimmune, it is systemic. And we will cover that in detail in the next talk, but Dr. Jayes will cover.
Okay, thanks for a wonderful lecture, Dr. Said.
Thank you.
How frequently we get basically a PUK in herpes simplex infections?
Herpes simplex does not cause PUK.
But
Herpes-
it has been seen the peripheral keratitis is caused by HSK as well, and they are treating it with it.
So the peripheral, herpetic infection can happen. This is an infective origin. So there are clues to the herpetic infection. First, there is loss of sensation. Second, there is the history of the patients having repeated herpetic infection. And then you don't want to get steroids if you have you might have KPs, you may have AC reaction, you'll have other signs of herpes. You're not going to present with a PUK like
right
this.
Now in the etiology of PUK, herpes simplex is a common etiology now.
We have a talk on differential diagnosis next. So.
Okay. Thank you.